Greetings, salutations, everybody. Dr. Ryan here, board certified specialist internist. Today we're unpacking acute kidney injury. I strongly encourage you to subscribe to my channel so you don't miss any exciting upcoming content in the beautiful world of internal medicine. Guys, let's break down acute kidney injury, right? So acute kidney injury is defined as abrupt kidney dysfunction as measured by a glomerular filtration rate of below 0.5 mils per kg per hour for at least 6 hours, or an abrupt increase in your creatinine and diminish EGFR over 24 hours. All right, so our causes of acute kidney injury can be substratified into that which is pre-renal, intrinsic renal, and then we got post-renal. Okay, let me just move that up. Can I? Oh dear. Yeah, there we are. Alrighty. So, and intrinsic renal is further subdivided into vascular etiologies, that which affects glomerular disease, that which affects acute tubular necrosis, or acute tubular necrosis, and then we have acute interstitial nephritis. So pre-renal essentially has to do with either, the blood volume, the vessels, or the heart. In essence, what causes hypovolemia? Things like poor oral intake, gastrointestinal losses, vomiting and diarrhea, overzealous diuresis, hemorrhage, or insensitive losses. Medications as well can cause pre-renal impairment. Cardiorenal syndrome. There's 5 flavors, but 2 speak specifically to cardiac etiology causing diminished renal perfusion. Distributive shock, right? Hypercalcemia, as we know, hepatorenal syndrome, renal artery stenosis, especially bilateral, and abdominal compartment syndrome. Right, looking at intrinsic renal failure and vascular etiologies, well, we sub-partition it into medium-sized vessels and small vessels, right? So medium-sized vessels, you can have an embolus to those little vessels, you can have a thrombus in situ formation, you can have vasculitis. And small vessel can be arteriothromboembolism or arterioembolism, thrombotic microangiopathy, classically thrombotic thrombocytopenic purpura TTP. We also got DIC, which are forerunners, but there's a whole lot of other examples as well, like hemolytic uremic syndrome, valve hemolysis, disseminated carcinomatosis, and so forth. And vasculitis itself can cause renovascular hypertension. It can cause AKI. Glomerular disease we're going to focus on in a separate video altogether, but there we're honing onto nephrotic and nephritic syndrome essentially, right? Acute tubular necrosis on the basis of ischemia on the pre-renal spectrum. So if you've got pre-renal AKI which goes unchecked, eventually it will lead to sloughing and death of your tubular cells. We call that acute tubular necrosis, ATN. And then we got toxin-induced ATN on the back of medications. Contrast, pigment and protein. Pigment in the way of myoglobin and hemoglobin. All right. And then acute interstitial nephritis, examples with medications causing it, infections, autoimmune disease, and an entity called tubular interstitial nephritis and uveitis syndrome, TINU. Post-renal has to do with either mechanical obstruction or neurogenic bladder. Mechanical obstruction, especially in the older men with benign prostatic hyperplasia, prostate cancer, the tumor usually, prostate cancer is the poster child for that, and nephrolithiasis, which is renal calculi, right? And neurogenic bladder in the way of medication, diarrhea, don't forget diabetes causing it as well. So guys, if AKI goes unchecked, it will lead eventually to chronic kidney disease. And this is a beautiful illustration from MedComic showing us the KDIGO stages. There's 5 different stages, 1 through 5. So 1, we have kidney damage with normal or increased GFR. The GFR is above 90. The nephron is happy. Our aim of treatment here is to diagnose and treat underlying conditions and comorbidities. Stage 2 is mild with the GFR is between 60 to 89. And our role here is to estimate the rate of progression. Stage 3 is moderate, with further partition to 3A, which is between 45 and 60, and stage 3B, which is between 30 and 45, right? And here we want to evaluate and treat complications, right? Stage 4 is rather severe, with the GFR dropping to between 15 to 29, and here we've got to prepare for some kind of renal replacement. Stage 5 is overt kidney failure, with the GFR dipping below 15, and here we need to dialyze or transplant if indeed uremic. My friends, allow me to just speak for a few moments on giving, right? By giving, we personify the nature of Christ, because God so loved the world, John 3:16, that he gave his only begotten Son. Whomsoever shall believe in him shall not perish, but inherit everlasting life. So in giving, we know that it is greater to give than to receive. We are blessed in order to be a blessing to others, be it in finances, be it in teaching, be it in food, be it in clothing, be it in any kind of resource. We are blessed to be a blessing. In giving, we are imitating Christ, and we quoted John 3:16. It validates one's faith if you give, right? It invites God's blessings. You are setting up an antenna for God's grace to flow in and through you. And we can't worship unless we are givers, right? And G glorifies God. So here we have 6 reasons why we should give. And I pray that we will be givers. Amen. Have yourself a fantastic day. I'll see you soon with another handy approach in internal medicine. God bless you. Take care.